Okay.
Good evening, everyone.
Yes. Should I?
Yes, sir.
Hello?
Yes, sir. No, Dr.
Hello.
Bansal would address as a welcome address. He's our president of Ambala Ophthalmological Society, so he'll be addressing us.
Yes. Good evening, everybody. Welcome you all on behalf of the Ambala Ophthalmological Society to this webinar, Outsmart the COVID bug. So you see, after a prolonged lockdown of more than 6 weeks, now the things have started moving slowly, and we have also started our OPD and OT work partly. We had 2 webinars last week, which were very successful, and they were attended by a wide number of people and acclaimed by each and everybody. And today we are hosting this webinar, which is on which we are focusing on 2 very important things. That is disinfection and the patient flow management, which is very important. And we have eminent faculty from a prestigious institute LVPI from Hyderabad. We have Dr. Savitri Sharma, ocular microbiologist, and Dr. Subhadra Jalal from Retinal Services, who have spared their valuable time for this webinar. I welcome them. And I also welcome our panelists, Dr. G.S. Dhami, Dr. Brad, Dr. Rohit Om Prakash, Dr. Praveen Arora, Dr. Kapil, and Dr. Vikas. I hope this webinar will be of immense help to everybody. Thank you. Now I ask Dr. Amit to start the proceedings.
Good evening, everyone. At the outset, I'll request everyone to please switch off their mic so that only the speaker is speaking. There won't be any echo. We have had 2 very good webinars where we have discussed the OPD and OT flow, where we have discussed the NABH implications and financial implications. But in the backdrop of new AOS guidelines coming in, we have some further insights, how to resume our practices, how to build up our practices, and how to deal with this post-COVID scenario. We are in the midst of a pandemic and we don't know how exactly it will pan out. Things are really very dynamic and we'll have further changes in the due course of time. To have a discussion on this, we have 2 very eminent speakers of international renowned. They have huge number of publications to begin with. These are speakers we don't need introduction to, but this is a formality that we'll have to do. First of all, Dr. Savitri Sharma would be speaking, who's a postgraduate from Jipmer, Pondicherry. Then she has been doing ocular microbiology work since 1986. She joined LV Prasad Eye Institute, Hyderabad, as an ocular microbiologist, and way back in 1991, she has been awarded with her. If I start reading her awards and honors, whole webinar would go in that list itself. She has more than 300 publications to her credit, 18 book chapters. She has written a book on ocular microbiology, and if I name any entity in ocular microbiology, she has reported first of them all across India, most of everything. Over to Dr. Savitri. She'll give us what are the basic insights into what all we have been reading which disinfectant to use, but what is the rationale that we are using this disinfectant and which disinfectant should be used. She'll give an insight into that.
Thank you, Amit. And thank you everyone from Ambala Ophthalmology Society for organizing this webinar. I'll share my screen now. Is that okay?
You need to share a screen.
Yeah.
सरका वो म्यूट कर दो उसको म्यूट एंड वॉल्यूम भी कम कर दो
How do I choose my screen?
Ma'am, there is a green dot at the bottom center of your screen.
No, you have to first open your PowerPoint. उसको खुला रखिए.
हाँ.
फिर जब आप शेयर स्क्रीन करेंगे तो आपको वो दिखेगा, तो फिर आप उस पर क्लिक करिए. पहले PowerPoint को खोल दीजिए.
हाँ, खुला है.
हाँ, अब आप शेयर स्क्रीन, नीचे बटन है. Just move your arrow down. You will see share screen green button. उसको क्लिक करिए. आपका कर्सर मूव करिए तो नीचे आपको दिखेगा शेयर स्क्रीन.
हाँ, वो दिखा ग्रीन. मैंने क्लिक भी किया.
हाँ, बस अब आपका डेस्कटॉप दिख जाएगा आपको, जहाँ पे आपने पावरपॉइंट खोला.
दिख रहा है आप लोगों को?
नहीं, अभी नहीं. आपको अपने पावरपॉइंट पे क्लिक करना. Once you say share screen, उसको क्लिक करेंगे तो आपका पूरा डेस्कटॉप आपको दिख जाएगा, जहाँ आपने पावरपॉइंट खोल के रखा है.
पूरा स्लाइड शो में रखूं मैं?
हाँ, स्लाइड शो में.
ओके.
हाँ, लेकिन वो अभी शेयर नहीं हुआ.
शेयर नहीं हुआ?
हाँ, आप फिर से शेयर को क्लिक करिए, डबल क्लिक करिए शेयर को.
Actually, if I do complete slideshow, then I can't see the screen.
Okay, then you put in non-slideshow, and once it comes, then you can go back to share screen. You click on share screen.
Yeah.
और आपका PowerPoint तो आप उसको क्लिक करिए, फिर वो आ जाएगा. Later you can go to slideshow.
वो ऑटोमेटिकली नहीं आ रहा है.
नहीं, अभी नहीं आया.
Ma'am, just
आपने
click
share
on
screen को
Zoom
किया
logo
click?
and then.
इसको डबल क्लिक करिए शेयर स्क्रीन को.
डबल क्लिक करना.
हाँ, तो उसके बाद आपका फाइल दिखेगा ना आपको डेस्कटॉप पे. बस उस फाइल पे क्लिक कर, पावरपॉइंट पे.
वो मेरा फाइल तो खुला हुआ है, पर इट इज शोइंग समथिंग माइक्रोसॉफ्ट, वन ड्राइव, गूगल ड्राइव, बॉक्स, ये सब क्या है? हाँ, अब
Hello.
अब दिखा.
हाँ, आपका उसी में आपको दिखेगा कहीं पे. हाँ,
हाँ, दिखा.
Yeah.
now you go to slideshow.
We can see it now.
हाँ, ओके.
Yeah.
अब दिख रहा है.
Rest everyone, please mute your mics.
Okay, good evening, everybody. I hope everyone can hear. As you can see, my first slide has a picture of someone who is very exhausted with information, but feels that she or he is still not wise enough. And I feel the same way. And I'm sure all of us feel the same way. We hear and know, read so much, and then remain clueless about so many things. Someone said that a lot of people think they're already PhD in coronavirus through WhatsApp and Google universities. And still, we don't know so many things. So the topic Amit gave me was microbiological rationale for disinfection, and whatever we have done in our hospital and whatever we have learned by reading and discussing with each other is what I'm going to present now. So next slide. Okay. So just to give a perspective of what's the size of the virus. You see a bacteria which is brown in color and it is attacked by so many viruses green in color. So that's the size difference. We talk about fungus and bacteria in micrometers, whereas virus is talked about in nanometers. And what is a nanometer? You divide 1 millimeter into 1,000 times of micrometers, and one of that micrometer will be 1,000 nanometers. So we can imagine what we are talking about. And this coronavirus, which is causing the pandemic, is 120 to 160 nanometers in size, and it is somewhere here, down here. It's not a very small one. There are even smaller viruses like 20 nanometers. but this one is around 120 to 160 nanometers, a slightly bigger virus. Now, by far we know that viruses are the smallest microbes. They consist of genetic material, only DNA or RNA. They don't have both. And that's why they are not a cell. They need a cell to multiply in. And that's why they don't survive outside in the atmosphere for a long time, because they always need a cell to survive. And they take over the genetic material of the cell, in which the host cell, and then they grow in that. They cannot move by themselves, so therefore they don't spread on their own by moving. They need to be carried by air currents or body fluids. And some of the viruses may remain we know in ophthalmology, HSV can remain dormant for a very long time, and throughout the life, and in between it can cause the infection. So we are familiar with the latency of the viruses. Now here is a virus. It is actually influenza virus, because I got a good picture to show the RNA which is inside. The red coiled thing is the RNA. And this coiled RNA is, in case of coronavirus, which we are dealing with, is single-stranded, positive strand of RNA. It is covered with the protein molecules which are forming the capsid, and they form N protein, M protein. There are so many proteins. And this is covered with an envelope. This is very important. This envelope is actually acquired by the virus when it is coming out of the host cell, and it is derived from the host cell. And that has many spikes of, again, proteins. And in case of coronavirus we are dealing with, it is S protein, which is the most important one for causing infection. When a virus enters a cell, it has to be recognized as a cell surface. And in case of this coronavirus, it is the ACE enzyme 2, which is present on the lung cells. And now I read that it is also present on the cornea and conjunctiva. ACE2 is present. And this S2, S protein can combine with that and find an entry into the cell. It gets attached, then enters, and here you can see that the RNA comes out from the nucleocapsid, and it translates. Here it is written transcription, but in case of coronavirus we are dealing with, it directly translates into proteins. So it saves some time, and it is very fast in developing proteins which are required by itself. And it uses the cell ribosomes to make its proteins, and then it gets assembled. And as it is coming out, it takes the envelope of the cell. So this cell envelope is actually derived from the host. This is very important. I'll tell you in the next slides why. As the size suggests, we cannot see the virus by normal microscopes we have in the laboratory. We require electron microscope. And also we cannot grow them in artificial media like blood agar, chocolate agar. They need to be inoculated in animals or embryonated eggs, which are not done so often these days. And what is done very often is tissue culture nowadays. We grow viruses in tissue culture. We grow cells. You can see a monolayer of epithelial cells here in green color. And inside the cells, we can inoculate the virus to grow. Now let's see what is a virus. The name of the virus we are dealing with is SARS-CoV-2. And this virus is causing the disease, and the disease is COVID-19. Just to get the terminology correctly. Disease is COVID-19, CoV disease 19, 2019, and virus is SARS-CoV-2. There was a SARS-CoV earlier, which had caused a certain amount of epidemics in certain countries, including India, and more we will be knowing about that. Now look at this, the infected person coughs, and the droplets not only transfer to another person directly, but also indirectly through, here is a computer, hand, and through the air. And there is some noise and some talk about through stool, fecal oral route, but I did not find very solid proof about that transmission through fecal oral route. Now, what are we worried about? We are worried because we are exposed to the infection of the virus, and there can be very few particles of the virus required for causing infection in another person. So let's say around 1,000 SARS-CoV-2 particles are only required, and one can get that from another person just in either in one breath or one eye rub or maybe 10 breaths, because as you can see below, in single breath also there is a release of 50 to 5,000 droplets of fluid containing the virus particles. And nearly 33 particles have been determined per minute coming out from in the breath, just in breath without coughing. If one coughs, it is so much more multiplied. Single cough, 3,000 droplets at the speed of 50 miles per hour, and single sneeze is 30,000 droplets. So, and each single cough or sneeze may contain 200 million of the virus particles. So the highly infective nature of the virus is what we are afraid of. And then what's important for us in dealing with patients is about the speaking. The speaking itself has been shown to increase the number of viruses coming out of the breath of the person who is talking, and can be dangerous for the person who is sitting opposite to that person. However, please remember that exposure to the virus is always linked to the time of exposure. How long that exposure was there is also important for successful infection. Therefore, it's a common sense that indoor spaces where we have our OPD examination rooms and OR rooms are closed spaces. And that is where a very large number of virus that comes out from the patient while talking or while coughing or sneezing is likely to remain in that room. In a closed space, actually, I agree that social distancing doesn't mean much, because 6 feet of distance is not very large in a space where the virus can just be present and keep on coming out from that person who is sitting there with the infection in large numbers. A low dose of the virus in the air can reach people over a sustained period of time is similar to a large number reaching at one time. So social distancing is making more sense when it is in outdoor, where you are just walking and someone just is talking to you from it is an open space. Then it makes distance, but indoors it is actually very, very dangerous whether you keep a distance or not. And therefore wearing mask is very much justified indoors and not so much outdoors. But the irony is, we are so afraid of this virus. It is so infective, highly infective. When we talk in those terms, look at the weakness the virus has. The virus is actually very, very weak. This slide needs to be looked at carefully. You have resistant organisms on top and susceptibles below, in order of susceptibility. So you look at this prions, which we know they call CJ disease. We studied in our, you must have studied during MBBS, causes brain disease, prion disease in cannibals, those who eat brains. Bacterial spores, we are aware of Bacillus species. And Cryptosporidium is a parasite. Mycobacteria, we all know. And here is a small non-lipid virus which does not have envelope. I showed you an envelope for the influenza virus structure. Now, those viruses which do not have envelope, they are called non-lipid or small viruses. And then comes the fungus, then the vegetative bacteria, we all know, Pseudomonas, Staph aureus. But look at the virus we are talking about. The coronavirus or SARS-CoV-2 is actually a lipid medium-sized virus. So it is the most susceptible. That's the irony. It is very infective, but it is very, very susceptible. So it is not very hard to kill is what I'm trying to tell. The level of disinfection is charted here, and to kill the upper ones, which are very resistant, you need actually sterilization or very high level of disinfection. I'll be again telling you about these in next slides, or intermediate level of disinfection. But where is this lipid and R virus? The virus we are talking about needs only low level of disinfection. So first thing we have to remember, it is not difficult to kill, but it's the problem we are facing is the widespread and the spread of the virus and not its resistance to killing. To go further, I would like to give some definition just as a reminder. By sterilization, we mean a process which will kill everything. And everything includes the spores of the bacteria, which in the previous slide I showed you are very resistant. So they must die. Only then it is sterilization. And what are the physical methods of sterilization? Autoclaving. So you know that autoclaving is going to kill the virus. Definitely. ETO sterilization, hot air oven sterilization, plasma sterilization, everything is going to actually get rid of the virus along with all other things. Chemical methods are the sterilant. The chemicals which remove the spores are called high-level disinfectants, and they sterilize. And in that group, you have formaldehyde, glutaraldehyde, hydrogen peroxide, and peracetic acid. But what is disinfection? It's a process that eliminates lots of pathogenic microorganisms, but not necessarily take out the spores. It may remove mycobacteria, vegetative bacteria, fungi, and most viruses, but it may not kill the bacterial spores. And this term disinfection is for inanimate objects. You always disinfect one inanimate object. You don't disinfect one hand, or you don't, a living thing you don't disinfect, only inanimate objects. And cleaning, we all understand, removal of visible soil is cleaning, and decontamination is removal of pathogenic microorganisms from objects so they are safe to handle. So these are some of the definitions. There will be many factors which will affect the efficacy of disinfection and sterilization. We all know that anything we are going to sterilize or we are going to disinfect should be first clean. We should be cleaned and removed. All soil and other things must be removed. That's why we always wash first, and then only we send something for disinfection or sterilization, and not directly. So number and location of microorganism, innate resistance of the micro, we already saw the organisms which might be resistant. Concentration and potency of the disinfectant matters, except for iodine. Iodine at any concentration is very, very good disinfectant, but others, if they are higher concentration, they are better. They become intermediate level of disinfectant. If they are lower concentration, they are low level of disinfectant. Several physical and chemical factors like temperature, pH, relative humidity, water hardness, all that may matter for disinfection of the material. Organic and inorganic matter, duration of exposure, and presence of biofilms. We know especially in medical terms that there are certain items which are critical and they need to be always sterile. You have to sterilize them, and that includes surgical instruments. There is no compromise in that. Whereas semi-critical items are those which contact mucous membrane or non-intact skin. And in this category comes the anesthesia equipment, endoscopes, and in case of our OPD, the Applanation tonometer comes under semi-critical item, and syringing probes, they also come under semi-critical items. So they need not be totally sterile, or at least the bacteria spores are permissible. And the semi-critical items minimally require high level of disinfection using chemical disinfectants. So let's see some more about what's the information available about the Applanation tonometers. A CDC, Center for Disease Control, recommends that tonometer tips be wiped clean and disinfected for 5 to 10 minutes with either hydrogen peroxide, somewhere is written chlorine, somewhere it is written ethyl alcohol, and also isopropyl alcohol. There are some controversial reports, like a report says that 3% hydrogen peroxide and isopropyl alcohol will not be effective against adenovirus. Many people quote this to actually defame alcohol, and they don't want to use or say about alcohol, quoting this article that it does not kill adenovirus. But because a short and simple decontamination procedure is desirable in the clinical setting in the OPD, swabbing the tonometer tip with a 70% isopropyl alcohol wipe is the practical thing to do. Wiping the tonometer tip with an alcohol swab and then allowing the alcohol to evaporate. You have to wait for some time. The exposure time is important. And that can get rid of many viruses. Also, CDC has recommended 1 in 10 dilution of sodium hypochlorite, which is available, and 3% hydrogen peroxide disinfection at the beginning and end of the day, but in between, you keep on using the alcohol wipe. Non-critical items are like bedpan, blood pressure, cuffs, crutches, computers. All these, they have no risk, has been documented for transmission of infectious agents to patients through non-critical items if they are used only for non-critical purposes and non-intact skin is being touched. Now here is a list. I was very happy to find and get this list, which is directly connected with the SARS-CoV-2 we are talking about and not a surrogate from somewhere. So this is a list, though it is based on testing of viruses which are not SARS-CoV-2, but they are being tested against viruses. And these are all different viruses which have been tested against these compounds, and they include different types: quaternary ammonium compound with alcohol, only quaternary compound with ethanol, that is ethyl alcohol, and quaternary compound with 2 other kinds of alcohols: hydrogen peroxide, hypochlorous acid, sodium hypochlorite, phenol. I have actually, this list is very huge, but I only took out the ones we are all familiar with, which we know and we have heard about, and they are available. And these have been tested against these viruses, and you can see that the contact time varies from 3 to 10 minutes. So exposure time to disinfectant is very important to achieve adequate disinfection. And this is all which are registered under EPA, that is Environmental Protection Agency of the US, and they are all good compounds. You can note the Betadine here, which is actually tested against the SARS-CoV-1. The first SARS-CoV virus was called just CoV, and current one is 2. So this was SARS-CoV and also MERS-CoV. But CDC guidelines have changed a little bit from 1981. And what is a change? They have removed formaldehyde. You notice that in the list I showed you in the previous slide, there is no formaldehyde. There is no glutaraldehyde. They have removed these as from the list of high-level disinfectants. They have included hydrogen peroxide and peracetic acid and very few indications for glutaraldehyde. They have also removed phenolic, iodophor, isopropyl alcohol, these from high-level disinfectants. These are all low-level or they are intermediate level of disinfectant. So except for hydrogen peroxide and glutaraldehyde, peracetic acid, which we don't get, there is no product available for hospital use. They're mainly used in the industry. We have all low-level or intermediate level of disinfectants available to us, to which SARS-CoV-2 is actually susceptible. Now here is a reference, I was happy to find that the compounds that which we are using, I think just before the meeting started also, we talked about sodium hypochlorite and ethanol. I also want to bring to your notice the quaternary compounds. These three compounds have been tested with murine hepatitis virus as a surrogate for SARS-CoV. And these three are very important to us because currently WHO and CDC all are recommending use of these disinfectants in different forms for different purposes. And they have been tested. They reduce the virus count by 3-log reduction when this virus, murine hepatitis virus, is tested against these 3 disinfectants. We are most familiar with Betadine, and there are so many products of Betadine which are there in the market and on the websites. And this has a very, very good effect, very highly effective against a wide range of organisms, including the virus. Highly effective against MERS-CoV, which was this Middle East respiratory syndrome virus, severe acute respiratory syndrome virus. And it is virucidal. Also, it has been tested against Ebola virus, norovirus, influenza virus. So directly also against viruses, Betadine has been tested. And we should have no doubt to take Betadine for granted that it will kill the virus. Sterillium, alcohol, as I showed you previously with the murine hepatitis virus, this also has been tested. And it has been found to be very, very effective. It's a liquid mixture of many alcohols, and some of the preparations have also skin conditioners and other things to make it soft for the skin. And sanitizers have little less soft alcohol. This Sterillium is suitable for hygienic and surgical rubbing hand disinfection. So I think now the whole market is loaded with Sterillium, and I hope they are of good quality. And what they write on top of the bottle, and I hope it contains that. And they are bactericidal, mycobactericidal, fungicidal, and virucidal. The one which has become very famous with SARS-CoV-2, and it wasn't so famous earlier, is sodium hypochlorite. I think many people, when they read about sodium hypochlorite, they were wondering where do you get it, how does it look, and how to use it. So much of literature has built up after its efficacy was shown against SARS-CoV-2, but it is nothing but the bleach. We all know bleaching powder, chlorine used for water disinfection. It is the same thing. And in different concentrations it is used. In drinking water facilities, 12% sodium hypochlorite is a primary disinfectant. The thing to be careful about sodium hypochlorite is it can degrade. As it is kept in the bottle or in the can, it can degrade. Therefore, we have to look at the expiry date very carefully, and we have to make it as per the manufacturer's instructions and not make it and keep it and use it later. It has to be made fresh. So these are the things about the sodium hypochlorite, and the recommended dilutions are always mentioned on the bottle, and we must use it in that concentration. Another compound which has become very famous now is quaternary ammonium compounds. They have actually taken over the glutaraldehyde and formaldehyde because of the toxic nature of formaldehyde and glutaraldehyde. Quaternary ammonium compounds are preferred these days, and many companies have come with the preparations which are very useful. Alkyldimethyl benzyl ammonium chloride. In ophthalmology, we know about benzylconium chloride, which is a preservative in some of the eye drops. And this ingredient has been designated by the Singaporean government to be effective against coronavirus because they have tested against, it was tested earlier against the SARS-CoV-1. And the assessment is based on published scientific studies on other coronaviruses. So quaternary ammonium compounds are the famous ones now, and they are in short brief, they are called quartz. They have become famous and replaced formaldehyde, glutaraldehyde, as I said. And here are some of the pictures. Now, someone actually recently asked me about Lysol. We all use, and many of us use Lysol at home for cleaning the floor. It has nice smell. You get in different smell. It is nothing but benzylconium chloride, 80%. I saw on the bottle in my house before I wrote this here. Benzylconium chloride, 80%. So it is good, this Lysol. And in our institute, we are using a preparation called Grenadier. Grenadier is also the same thing. It is Alkyldimethyl benzyl ammonium chloride, and we use it in 1%. We have another product, Dew Power, which is also the same quart, and it is used for the cleaning of the surfaces, the floor, and other things in the OPD and in the corridors and in the toilets. Now, all this information I'll go by slowly to mention in the areas practically where they are being used. So the protocol for the housekeeping is they must wear masks, they must wear gloves, and they clean the floor, chair, doors, knobs, tabletops, and toilets frequently. We have told them to, first we said, let them do 3 times a day, but sometimes it is practically difficult to do every area 3 times a day. So they do 2 to 3 times. And they clean using the prescribed disinfectant in the prescribed concentration. We prefer that the doors of waiting halls and examination rooms are kept open so that there is free movement and no one touches the door knobs, which are likely to be infected. The protocols for optometrists and ophthalmologists is to wear cap, mask, gloves, and visor. I'm sure, I hope visor is available everywhere now. In our institute, the innovation department, they made themselves, and now I think the prototype is also there on the website. One can easily make that. And I'm seeing pictures from other hospitals, especially Narayan Netralaya and in Bangalore, some hospitals. Doctors are wearing the visors. And it is a job of the optometrist or ophthalmologist to clean the slit lamp, computers, diagnostic equipment, the tonometers, using alcohol wipes and sterillium. And disposal of the mask is recommended to be in the yellow bucket. Placement of sterillium, it should be easily available, and masks should be easily available. So we keep in different places, like at the entrance with the security, reception tables, biometric counters, OPD corridors, counters, OPD examination rooms. And being expensive, we are able to give N95 masks mainly to optometrists and ophthalmologists. And in the OR, we are able to give it to the nurses and anesthetists and people who go close to the patient. And visors are also given to people who are facing talking patients. Patients are talking and they have to hear, and they have to talk to them. So receptionists, counselors, front desk staff, they need to have the visor. It is very controversial about, in our institute, there was a talk whether we want to have a disinfection tunnel before at the entry of the hospital. And after some discussion, we have ruled that out. Right now, we are not going for it. And the information that we have is what they spray in these tunnels is 0.5% sodium hypochlorite. And we really don't know what happens, how much it helps to make the patient free of this virus, because it will be only on the surface or the body or the clothes of the person. So we don't really know, but these again have also come into the market at the cost of around 10,000 and going up to 25 lakhs. So we really don't know. I think when we discuss, we'll talk about it, what others feel about it. There was someone who told me about we have to check whether the cleaning is good or not. I really don't believe in this. However, there is information that you can use adenosine triphosphate bioluminescence, something is available, which will give out light if there is a biological material which is not cleaned up. And there is a cutoff of 500 relative light units. I really don't know. I have not seen this. I have no experience. And I don't believe that you need to have something which will check for cleaning. Rather than that, we should be having an audit and surveillance of the protocols that we have made. And we must make sure that our protocols are followed. For that, you can have audit. You can have people go with a checklist and see whether this was done, that was done. A whole long list of checklists can be there. And people in the morning as well as in the evening, they can go and check and then make sure that things are happening rather than spend money and go for chemiluminescence and fluorescence and all that kind of checking. What do we do in OR? Actually, I was telling Dr. Subhadra that what am I going to say about OR, because I don't really believe that you need to change anything in the OR. In the OR, the methods we use for sterilization or for cleaning, now our product that which we are using is D125, which is again a quaternary ammonium compound, and we don't need to change. It is a good disinfectant and it kills the SARS-CoV-2. We don't need to change, except that we need to be covered. N95 masks, caps, and caps we always do. Scrub suit was also always there, but visor is one addition. So N95 mask and visor are the one additional things to protect yourself. And I had actually recommended that patients should also be masked. Earlier, we were not taking patients inside the OR with masks, but in this situation, we need to actually give masks if they have not come with masks, and also give them sterillium all the time, as many times as possible from the time they enter the gates of the hospital to coming into the OR. At several points, they can be given sterillium for using and in their hands to sanitize their hands. This is not really related to us, but it's a good information, which I was excited to see that from our own IIT Kharagpur, they have built a UV minus corona UV bot. So inspired by this requirement to kill the virus, two people have come together to build this device. You can see the device in the picture. It is a robotic thing. It just keeps moving into the hospital corridors and everywhere. And it actually what it does, it exposes the surfaces to UV light, ultraviolet, which definitely kills the virus. There is no doubt about it. Kills UV light would kill all types of microorganisms, and virus is very, very susceptible. We used this information about efficacy of UV for thinking how to reuse the visors that we are having. And we decided that the person who is using the visor at the end of the day will clean themselves. They'll clean it with alcohol on both sides. And then we have designed a room. I went and saw this room. It is still in the final stages of being made, which will have some wires to hang the visors. And on both sides, we'll have, this is a prototype, we'll be having UV tube lights, which will throw UV rays on both sides of the visor. So this is our plan. The room has been identified. One side UV lights are already fixed. We are thinking how to do on the other side. And this is going to help us to reuse the visors without much worry. I would now go to a list which our consultants, our doctors have made for different diagnostic areas in the OPD. And some of them are already we have discussed before. So about the slit lamp, We actually are using alcohol wipes or Sterillium for cleaning the chin rest, headrest, knobs, control buttons, and same thing for ASOCT. Everywhere, actually, what we are using is the alcohol or Sterillium. Wherever the patient is body is likely to touch, those are the area that must be cleaned. So this all list is made by the people working in the OPD. Similarly, in glaucoma, here only additional thing is about the Yag laser. They have said that the lens should be cleaned with soap and water after every case and alcohol swab before use for a new patient. And tonometer, we have already discussed about that. Gonioscope lens also is soap and water after every case and clean with alcohol wipe before performing the test. So with this, I would recommend, and I just got it 2 days back, this particular 100-page document from All India Ophthalmology Society. It answers a very large number of questions. Almost everything has been taken care of. And I think all ophthalmologists should read this, and their doubts would be cleared about many, many things that we are facing. So with this, I'll stop. And thank you very much. And I'll be happy to take questions later after I think Dr. Subhadra finishes.
Should we take the questions now or after the second talk itself?
What do you feel? Whatever you feel. I'll stop share.
Yeah.
Okay.
Or I think we'll take it later on only because there might be some overlap with Dr. Subhadra's talk as well.
Yes, I think so.
So now I have the honor to introduce Dr. Subhadra, who has been one of my mentors as well. If I think of patient care, the first name that pops out in my mind is Dr. Subhadra's. She would take care of every need of the patient, right from the check-in to check-out. She'll take care of the patient in entirety. She has been a postgraduate from PGI Chandigarh. Then she did her fellowship from Eli Prasad Eye Institute, Hyderabad. She had done a couple of more fellowships in ocular genetics, electrophysiology, posterior uveitis, and retinopathy of prematurity from US. Then she joined as faculty in Eli Prasad Eye Institute, Hyderabad, one of the first female full-time retina specialists in the country. She has been doing enormous work in retinopathy of prematurity, and she has trained more than 700 fellows in retinopathy of prematurity alone, apart from the retina fellows that she has trained. She has numerous publications, more than 150 publications and various book chapters to her credit, and the list of work just goes on and on. I'll request Dr. Subhadra to briefly outline what would be her method of OPD and OT flow and clinical flow in her setting.
Hi everyone. So
Hello.
I had shared, somebody has stopped the share screen. Somebody can put it back. Resume share. Okay. Okay, now how do I get this here? So you can see my screen? Hello, can you see my screen?
Yes, ma'am.
Yes, ma'am, it is visible.
Yes.
Okay, so we'll get going.
Yes, ma'am.
चलो, I can't see myself. Okay, I can see myself. मुझे भी देखना है अपने आप को. Okay, I'll put it here. चलो. Okay, so I think सबसे पहले तो देखो भाई, I am from Kashmir, and I have to tell you that this is where I come from, and this is the beautiful place. And maybe in this COVID situation, you are thinking, भाई क्या होगा, अब कैसा होगा, पता नहीं क्या होगा. So I just want to share some personal story of mine, that this is where I was, very nice life. My house was just next to the Dal Lake. It's still there. Those who want to visit are welcome. It is open throughout the year. And then you know what happened. In 1991, this is my 5-story bungalow house where we lived, enjoyed, combined family, and this is what happened in 91. Our life and livelihood was in dire danger. And this is my house, what has been left of it. So, some of you may be thinking ki abhi COVID hai, life and livelihood is in dire danger. I went through that. But what I want to say is, don't worry. Just be happy, do your work. Today, as Amit said, I'm on top of the world. I don't think, about what happened at that time. So I'm sure that, by next year or 2 years or 3 years, you will just reminiscence this once in a lifetime danger situation, and we'll all come out nicely. Just do your work and don't worry. Be happy. I used to dance even when I lost my house, and I do that even now. So what I want to share with you is how, what did we do at LV Prasad Institute and how we've gone about it, so that I can share and all of you can also see what happened. So the first thing is that we had a very early start because of Dr. Savitri being there. In fact, the first time we talked about this virus was on January 10. Remember, on January 7, this virus was detected. And this was because in our infection control committee meeting, we were discussing about conjunctivitis, and every month we give the conjunctivitis data. And we had heard that this virus can cause conjunctivitis, and that an ophthalmologist has detected it, and that ophthalmologist is being ostracized in Wuhan. So we just discussed about it, and then we said, okay, let us try to find something more about this. This looks exciting. So it was like just, something new is coming. So let's find out about it. And in the next HICC meeting in February 24, we realized that, it was spreading. You can see this chart in February 25, it was nowhere near us, but it was adjacent. It had still not, covered the Southeast Asian countries, but we were just, alert. And so we said that, let us start. So it was in February itself, before I think anybody in India was thinking about it, our strategy started. And by March 2nd, when the first case was reported from Hyderabad, we were actually ready. We were ready, and within that week, we could get all our, meeting done. And on March 8, our chairperson set up a war room with myself, Dr. Savitri, and Dr. Rajiv Reddy, and then we added Rohit. So, it was very, very quick, because we had, a lot of information from Dr. Savitri about the microbiology, infection control, quality approach. And on March 18, we actually closed down our hospital, which was 1 week before there was a lockdown in the country. So what I want to say is that our well had been dug up in advance to give us the water when it was needed, and that was because all the teams were there and we were alert. But I think it was just serendipity, because this disease had, started from the eye in the news. Had there not been any conjunctivitis or that ophthalmology story, maybe we wouldn't have worried about. I mean, so many epidemics are heard in different parts, like Ebola and other things. We never went into depth of those. So I just wanted to say that, how we have to train our people. So this is just to show that, you can put up everything there, and you've set the protocol, you've called everybody, you trained them, you see. So by March 18, when we shut down after March 8, we set up and we said, okay, let's train. So we just called the front desk staff, because they are the frontliners. They are going to face these people. And we trained them. And you can see this is our surveillance. So Dr. Savitri was saying, you don't have to get fancy things. You just need somebody on the ground to monitor and see, did they understand what I told them? And you can see here that, most of the people in the front desk, even after 4 days of surveillance, did not really remember the emergency number. They didn't know where it was. But when it came to asking the patient for the symptoms, like travel history, fever, personal hygiene, so they had learned this very quickly, whereas initially few days they did not learn. So we could immediately know what part they have learned, what part was easy for them, what part was not easy, what we have to stress in the next class, what we have to stress. So when you take class, or you do the training, or you set up some protocol, it's very important for next 3, 4, 5 days. You have to monitor, and then they get the behavior change, and then they fall in place, and then they know somebody is watching, somebody is checking, the checklist people are coming. So you can see very quickly they learned what happened. So this surveillance is very important whenever you start something new. The other thing was, as Dr. Savitri said, there's a lot of data coming in, so many literature, so much. So it requires a team effort and an evidence-based approach. So me and Dr. Savitri couldn't read all the literature that was coming. So we, went around and we found our colleagues who are very studious and good at it. So Rohit Khanna, epidemiologist, Murlidhar, who's very meticulous. So then Praveen Krishna. So even in yourself, suppose Ambala is a small city, you might think, okay, I'm in a small hospital, but all of you are great people. So you can, allocate the topic. Okay, Amit, this week just find out about the masks. Okay, no, Dr. Bansal, can you find out about the sterilization bottles? So we can team together and find out. So this is the report that Praveen Krishna said. That okay, there are a lot of companies making the mask, but we don't know what is the quality. So let's go with the best ones. So we get. So should we give hydroxychloroquine? So Rohit Khanna goes and reads all the literature and then tells us whether we should stock it or not. So we can have a consensus and they can give us the evidence. So that discussion is very important when there is so much of information coming and the information is rapidly changing from day to day. How one day one thing is good and next day it's not good. That happens in literature over months and years, but here it's happening every day. So we need these studious people to be there on the front line who will read and then get us some evidence based information rather than something which is coming just like that here and there. So we do look at everything, but we have a team who's expert in that. And of course we try to find out from other people. So we connected to people in Italy, in Singapore, Dr. Lingam Gopal. We connected to people in Taiwan. So we were getting good information from various countries, all these people that we could connect and find out what they are doing, what's happening, and so we could make our protocol. Now, I think it's very important for all of us. The world is changing. It was already there in our minds to go to teleophthalmology. People had already started, but we were not prepared for this. We were not prepared that it will be a complete lockdown and we will have to, accelerate this. We thought over the next 1 or 2 years, we'll be looking at it. So we had to really do it very fast. And I think many of you are already doing it on your cell phone or WhatsApp. So in the first phase, what we did was that all the faculty and fellows were handed over the teleconsults and the patient used to call, and we had a Google sheet which we had to fill about what the patient is asking for. So if patient just needed an appointment after 2 weeks or 3 weeks, or they needed some drops or they needed some information, so we used to fill this up so that we have an information which we can connect later to the patient, because we were not entering it directly into our electronic medical record. And of course there are a lot of things that we learned that the patients could tell us. They could take their good anti-segment photography. Many of them had WhatsApp, so they could send us the pictures. They could describe the symptoms. They could even send us video calls. So any current reports they could send. So there was this thing happening, but this we started free of charge initially. And the Government of India guideline helped, because during this time, I think this is one thing all of us should just take good advantage. Normally the government takes years and years to listen to us or to get us something going. Now because of this COVID crisis, I think government is just fast tracking so many things that we were waiting for years. And the best source is the Ministry of Health, Government of India website. If you go there, they have beautiful protocols, they have beautiful videos, lot of material. You can use it, and every day there's an update. So the moment we heard, the Government of India has cleared telemedicine from legal sides, so it will help you. You just download the document and then okay, I'm on the correct track, so I don't have to worry about whether it is legal, illegal. Previously it was not legal, so what part is legal? So currently the Government of India has made the only part which is illegal is that you cannot do teleconsult for a person who is outside India, somebody who's abroad. So you cannot teleconsult that person or give a prescription to that person, but otherwise anybody within the country, we are allowed to do that. So I think just keep your head up and just be after the government guideline, whatever they are doing, just grab that opportunity so that you can make the best out of it at this point of time. So later in the phase 2, we quickly realized that many of the hospitals in Hyderabad were actually charging these patients and actually charging quite a bit. So we said, why are we not charging? So we immediately went, and now of course we have a charge which is the same as the OPD charge. Currently it is 250 rupees. But what we can do now is that we can sort of track the patients on the phone, get their history on the phone, and now it is connected to our EMR. So every teleconsult is checked in as an OPD patient, and we are able to enter everything on that. And if they upload a photo or something, we can connect that also. So now it's very nice. So I think all of you can start this in your clinic also. There is no difficulty. You can do it in various ways. So some people are, even in their own clinic. So they are saying, because we don't want to face the patient for longer time, I am sitting in the clinic, patient is also in the hospital, but I am talking on the phone or on the video call and taking all the history and everything, and then only calling the patient into the room just for the examination. So these things we can do, and it is not like very expensive thing to do. If you have good signal in your hospital, you can do these things. Then the other thing that we also went beyond. So this teleconsult is just not, the machine part or the medical part. I think what Dr. Rao wrote some last year when he was talking about technology and medicine, he said, the protocols which bring the human face and the empathy of a medical profession into marriage with technology, that is where we are going to do best. And this was his idea. He asked all the vision centers. We have a lot of rural centers, they were completely shut down, right from the village level to the town level. 208 centers were closed down. So he said that everybody should call the patients. So we made 90,000 calls. All the patients in our database in the villages have been called, and there were 3 questions asked to that patients. How are you doing? Is everything okay with you in this COVID time? The second, do you have any problem in the eye, like redness, watering, itching? If they wanted, then they could talk to the doctor. These calls were made by the administrators. And then the third very important question, which I don't think anybody would ask, was, do you need any help from us? Is there anything that we can do for you? And you can see here the data. 91% said they were good, they were happy, they were very impressed that LV Prasad Institute was calling them. And 3% is a huge number out of 90,000 calls. So they had problems like redness, itching, watering, which we could address. And 1% of them wanted continuation of their drops, like they were on anti-glaucoma medication or something, so they wanted to know, should they continue, should they stop? So then 3% have booked an appointment with us, and I'll show you the data what happened because of that. 2% wanted surgical dates. So 2% of 90,000 is a huge number. And 1% of the patients, that is 53 patients, said that they were just on the brink of death or hunger or starvation, and they had nothing, and they were really in need. And then our staff, they have contributed and actually gone and given groceries and whatever help they need, or if they were stuck somewhere, help them to come out, wrote to the government or called the government and got them out of that dire situation. So 53 patients we could help actually beyond our medicine things. And currently we didn't have any salary cuts and no job losses at present. And all the people, the doctors, the senior doctors, they're all calling all the staff. We have more than 3,000 staff, so we are calling. We've sort of given groups of people to be called. So I am also calling, and everybody is calling to make sure that everybody is okay. And in the urban centers, we did call all the patients who were booked in April, May, June, yeah, and talk to them personally and explain to them what is happening, and then answered their queries and had to help them to reschedule appointments. So the other thing, which is a big thing, this is for bigger hospitals, but it could be a question for smaller hospitals also. Like, we have so many people, our staff, and normally we communicate in a certain way, but when everything is locked down, we are not sure whether we are communicating with everybody. Like, we had some protocols in place, we started something, but then we are changing many things. So for example, in our car campus, we have about 1,500 81 footfalls every time, and you can see these are about 59-60% are employees. There are a lot of students, trainees, and then there are a lot of these contract workers and people who come from outside sometimes. So if you see here, about 13% of these staff, 1,500, were actually having inadequate communication, and I've written here. And you can see here, these are very critical people: the security people, the canteen, cafeteria staff people, and the housekeeping people, because these are all 3 outsourced in our hospital. And so we were talking to the leader, but we have no idea whether that information is going down the, every member of these staff. And remember that these 3 groups, the food and the housekeeping and the security, who are at the front line, who are going to, allow the patient in or not in, they are the first barriers against entry of infection or entry of any, unsavory things happening in your center. So we really have to think, how do we reach these people? And so we put these into yellow and green and red and say, like, we need to think, how do we communicate to each one of them? It could be a secondary or third level communication, and we don't know whether they understood what we did or not. So now we're sort of doing more surveillance of the work of these people at that level. So out of the other people, like the 934 employees, you can see here what happened once we collected the data, that the email which we were sending, so everything is closed, so we are just sending emails. So only 55% of our staff actually was able to see the emails. And a larger person was on WhatsApp. but we didn't have access to those groups. These were groups which they have made themselves. I'll show you. So 87% on that, and 2% of our employees did not have a smartphone. So, if we were sending some message on WhatsApp or something, so they would not get it. Now, 23 departments out of the 52 had 41 WhatsApp groups. Okay, so but about 10% of people, we don't have the data. So what we did, we went to HR, we got all the phone numbers, we contacted all these people, and we tried to find out how are they connected to us in this time of lockdown. And you can see this is something we should do, because we need to find out how to communicate. So this is just an illustration. This is a big data, but I'm just showing, look at the doctors. They had at least 20, 30 email ID groups. And so we don't know the email that we are sending, it's going to them or not. And they also had a lot of subspecialty WhatsApp groups. So every doctor was connected to some subspecialty. Same with the optometrists and optometry. But look at the inpatient ward. So all the nurses in the inpatient ward, they had neither email nor any group ID. And so they were only having a WhatsApp group. So they have a WhatsApp group with a nursing head. So only the nursing head is able to tell them what to do. Otherwise, they have no direct communication with any of us. Same with the iBank. So, so we could sort of map out what's happening with the communication network. And so this is a work in progress, how to, make a WhatsApp. So doctors don't have a WhatsApp group. So we don't have a faculty WhatsApp group. You can see only the subspecialty people have WhatsApp group. So you can see here, if there's a comprehensive ophthalmologist at our institute, he is not in any group. So he's left out. And there may be other people who are left out, those who are not a cornea specialist or a retina specialist or a resident. So you can see how the gaps will occur. So we were trying to find out what are the gaps. So 1 or 2 doctors would be left out, those somebody who's in the field or somebody who was in comprehensive ophthalmology. He doesn't have a group. So that was one thing. So coming to, how do we manage in the OPD and all, I think this is very important, that fresh air, sunlight, they make this virus go away. So we should have an idea of how long the virus remains on various surfaces. It can last from 2 to 8 hours to 4 to 5 days. So that is the reason why we say that, if we are able to clean the surfaces, the floors and doorknobs and everything, at least 3 times a day, it will come every 3 to 4 hours. So, our OPD, let's say from 8 o'clock to 5 o'clock, it runs. Then, in those 7-8 hours, if we clean 2 or 3 times, then we are safe. So we have to have some idea how many times a day to clean the doorknobs and the steel handles and chairs and all. So if we clean every 3-4 hours, then we should be fine. So that is 2 or 3 times a day. Now, there was some controversy about Arogya Setu app. I am not sure how much it is helping. I don't know how many people have downloaded. I have not as yet. I'm trying to find out, really, will it help us to know anything about the patient or the staff? So the government has mandated that all hospital staff should have it from central government currently. So we have told, but we've not sort of made it very mandatory, and we've not checked whether everybody has this app. Maybe in discussion, I would like to know if somebody has used this for anything in the hospital and how it is working, whether we have enough traction on that. Now, coming to the PP, I think this is something which everybody is very confused by. Kya PP penna hai, kya PP, there's so much about PP. So I just want to tell how to, sort of rationalize. You don't have to, really go by something, but you need to understand what is this PP about. There are guidelines and there are guidelines. So if you see, what I understand is, firstly, that, the virus has exit points and it has entry points. So virus jo hai, this COVID-19 disease, the virus exits from the mouth, the nose, some amount from the eye tears, and it goes into the hands, and then it goes into the fomites. So basically, if there's a person with the virus, he is going to exit it out from his hands, nose, mouth, and something from the tears. So if we can block these parts of a human being, then the virus will not exit out. It will remain in his body. Now, even if it exits out, how is it going to enter into our body? So it will enter again through the same ports. So again, it will enter through the nose, through the mouth, through our own hands, and maybe it will enter through our eyes. And there's a small chance that it may enter through the, fecal-oral route. We may eat it. So if only these areas from where the virus can enter, so it can't enter through intact skin. Okay, it possibly possibly cannot enter through the blood. I don't know if it remains the blood and then enters through the blood, but mainly it is through mouth, nose, ears. So men, they said, don't hands. So if we try to block mouth, eyes, nose, and hands of one person to another person, then there will be no transmission. So if we understand this, then we can understand how to block transmission of the virus. So let's say in the non-clinical areas, people who work in the accounts department, gardeners, stores department. So these are people, you can have your own list. These are green people. Green people means that they can have virus exit points. Means they may be asymptomatic carriers. That staff member may be an asymptomatic carrier. Your neighbor, your vegetable vendor, your buy. So these are all people who can be asymptomatic carriers, and they will have virus exit points. So you need to block their exit points. So how do you block their exit points? You give them mask. You make them, sanitize their hands or wash their hands. You teach them respiratory etiquette by don't sneeze in front of everybody. Use your elbow or tissue if you are not wearing a mask at that time. Don't come to work if you are unwell or any family member is unwell, means if they have some upper respiratory infection symptoms. Don't go to clinical areas because you are green people. You only have problem with virus exit points. If you don't go to the clinical area, then you're not in an area where the virus can enter into you, so you won't have any entry point. Okay, maintain social distance. I think social distance is the most important thing, because if somebody is having an aerosol somewhere, especially as Dr. Savitri told, in closed spaces, then that aerosol can affect you. So if you maintain the distance, then the aerosol cannot travel all the way like 7, 8, 10 meters and infect you. So as long as you are maintaining that. So this green is basically people, one, who don't come to clinical area. Second, where two persons are not closer than 1 meter from each other. So if those two people, let's say there's an accounts department and two people are working there, and they can maintain that 2 meter distance or 3 meter distance or 1 meter distance from each other, and they're not using each other's computer, then they are in green area. And then that can be done. So of course we want to reduce the viral load if any of them is an asymptomatic carrier. So don't crowd people, have good ventilation, sunlight, do the cleaning up. So then these people are quite safe and they can come to work, and that is how they can work. So they are not at risk of a virus entering into them unless they sit next to a colleague who's infected. So the social distancing becomes very important, especially while they're eating or they're having a cup of coffee or something, or they're talking to each other, they're asking for something. So, if they're taking something from somewhere, so if they have to take a file from their colleagues, they should wash their hands. After they take the file, they should again wash their hands and not touch their face after touching the file. So those hygiene measures they have to learn. In the clinical areas, all the staff and all the entrants also, you may have visitors, vendors, whatever. So they are divided into two groups. Now this is the hospital part, the OPD, OR, the waiting areas. So they are either red or yellow. So anybody in clinic area is not green. They're either red or yellow. So the red are those who have to come closer than a meter, or where they are going to clean fluids. Let's say somebody is cleaning the toilet, so she's going to clean the urine of that patient. Okay, so two things. So red are people who cannot be maintain that social distance, which we said is very critical, or those who are going to handle the body fluids or blood or samples of the patient. And yellow are those people in the clinic who can maintain that distance, who can maintain that social distance, who don't have to touch anything of the patient. They are working with the patients, they are working in clinical areas. So now the yellow people, they will have the same virus exit points as the others. So they will maintain everything, as we said, because they can be asymptomatic carriers, but they can also have entry points. Okay, but the entry is medium risk. And this risk is only from aerosol or fomites, because they are not close up to the person. So they will not contact it from body fluids, like say tears or blood or saliva, or sharps like needles. So these people who are in yellow, they should have a triple surgical mask, because they're at medium risk of getting those aerosols, or they're touching fomite. They should have a face visor, because they are going to talk to the patient, hopefully at a distance. They don't have to sit close. They can put their markings on the floor, so that the visitor's chair and their chair is at least that much distance apart. And they should wear gloves. These are unsterile gloves, the one you use in cafeteria or by caterers and all. Not very expensive gloves, because if they handle some money, or they handle a file, or they give some paper. So they should have gloves, and then of course they should wash their hands. And it's good if they have a uniform or an overall, so that when they go home, they're not going in the same clothes which they are wearing in the clinical area, which is like a moderate infected area. And they should wear a cap, because they may touch things and then they'll touch their hair. Their whole hair should be enclosed in a cap, and that's not very expensive. They can use a surgical cap, or they can make a cap out of some stuff. Foot cover, if it is possible, it's good to have foot cover, because they are aerosol in that clinical area. But at least even if they don't have foot cover, they should at least have closed shoes. It's not good to wear sandals or chappals where some of the material from the floor is coming into their feet. Now the red people are the ones who have a high risk from aerosol fomites, because they are having a longer contact time with the patient, or they are very close to the patient, or they are going to handle, let's say, the tears or the discharge. Let's say the ringer lactate, like we are doing surgery and that ringer lactate flows on our gown. Many times all that fluid spills on us. So we don't know what is the viral load in that. We have no idea whether there is a viral load or not, but it's a contaminated fluid which is coming on us. So, or we are, taking some sample. So these are the people who are at red or high risk. And why they're at high risk? Because they have a longer contact time. They are much closer to the patient, or they may be handling body fluids. So these are the people in ophthalmology. And this is why you see the ophthalmologists and dentists, they have been shown to have the highest mortality rate and the highest infection rate, because we are not taking full precautions. We are not understanding that the virus is in the mouth. It may be in the conjunctiva or very close to that. So we need proper protection. So we should have N95 or equivalent mask. If in the OPD you can't have N95 mask, at least a double surgical mask, a face visor definitely. Don't talk to the patient and examine at the same time. Stand at a distance or sit at a distance, talk to the patient, and then tell them, when I'm examining you on slit lamp, or I'm doing your retinoscopy, or I'm doing your indirect ophthalmoscopy, you will not talk, and I will also not talk. We will talk only when we are at a distance. So when we are examining, we will not talk. We are so used to talking, so all the instructions you have to give with gestures. Don't talk when you're examining the patient. So gloves, yeah, sterile or unsterile, depending on where you are. If you're going to handle blood, sharps, just like HIV patients, you may want to wear double gloves. For the housekeeping, we give the heavy duty gloves, the orange ones. Then if you're going to be in a place where there is a blood spill expected, or a water expected, or like for HIV patient, then you can wear those disposable gowns. Otherwise you can wear linen gowns if you don't expect anything coming on you. Cap or hood. Goggles, now we can't do surgery with the visors. Those who are wearing prescription glasses, maybe they want to close the sides of your own glass with some plastic which you can clean and use your own glasses. And those who don't use glass, they may want to use a zero power glass or a goggle, white goggles. And then foot covers are important. And of course, very, very meticulous, avoid sharp injuries during this period. We don't want to have another thing happening there. So I just want to show you what is happening to us. This is real data. You can see in the secondary centers, these are week 1, this is first week of March to now the 10th week that we are going. You can see here week 1, this was our last year patients in the same months and weeks. And you can see here we were doing very well in our secondary centers, 20 of them. And then you can see in the first, second, third week, slowly the numbers were reducing. And 18th March, we closed down, and government closed on 23rd March. So we went down to 0. But you see what has happened now. So from last 10 days, we have opened up all our secondary centers. We've started surgery also there. And you can see this is the, what we got, because we kept in touch with all the patients. And of course, now we have a benchmark, like, we have to reach here. We don't know in how many weeks we'll reach here, but at least we've started that journey. So we've started. So we've seen about 2,000 patients in these 20 centers in the last week. So, so you can see here, actually in the secondary centers, we had a very good, rapid expansion. Of course, these are multiple centers, but I think also because patients don't want to travel to cities and there may be transport problems. So those who are closer by could come to those centers in the village area. But this is something happening, but we have a long way to go. But we have started the journey back. This is the surgical care. As I said, we just started surgery, so it's only 2-3 cases, but I think in next week or so, we should be doing more. So we are going cautious. We said, let's start 1 or 2 surgeries in the beginning and then see how it goes. These are elective surgeries, because in secondary centers, we don't do emergency surgeries. So these are elective cataract surgeries. So if you look at the tertiary centers, that is Hyderabad, Vizag, Bhubaneswar, and Vijayawada and Vishakhapatnam. So this is what has happened. So you can see here, this was our last year data. We have 16,000 plus patients. This is the data in March. And you can see here very rapidly we came down, we closed, and of course we were still running the emergency OPD. So we were seeing about 50 patients per day, and it has crossed about 300 now. So yesterday we saw about 300 patients. Out of that, I think about 80 to 90 are also teleconsults. So we are doing about 100 teleconsults per day now, and you can see the surgery. So we were doing emergency surgeries. We were doing a lot of ROP work because nobody else was doing ROP work. So our team was going out and doing a lot of ROP lasers. And you can see here now, when we started today, we did the first femtosecond, whatever it is called, cataract surgery, Zepto cataract surgery. We did the first one today. Premium package. So you can see here we've just started. So we are again going slow, and it's taking about 30 minutes turnover time. Previously it used to be 5 minutes, less than 5 minutes turnover time in the theater. It's about 20 to 25 minutes now, but I think we'll catch up. And so the things have started. So of course, Dr. Savitri told we did have a lot of people coming in from our own staff who built many things. This is the visor that they made, and they made it not only for us, but for the police department, for the self-help groups, and it's gone to more than tens of thousands of these masks, both national and international collaborations, and it's do it yourself. It's available on the website free, the thing. Then we had many other people. We've made this box for the anesthetist. So it's a large box with 2 holes, so that they don't have to be very close. So all the aerosol. So general anesthesia is the largest aerosol producing procedure that we do, both during intubation and extubation. So we have this box, which is there, very simple box made at home in the hospital with acrylic sheets. And so all the aerosol is there inside. It doesn't come to the anesthetist. You can see here. So you can also have a opening for the technician if you want to have that. Then Dr. Savitri already said that we are trying to make a UV room sanitization, and I will end with my small contribution. This is a garbage bag shield. I made it on the spur of the moment within 3-4 days of the onset of the COVID epidemic. And I thought this can be very easily given to our housekeeping staff, or if an electrician comes to our house, or any worker or anywhere. So I close with that. I will just run this video. It's a 2-minute video. This is a garbage bag to keep garbage out, virus out. So this is my disposable PPE. I didn't need to wait for very expensive. Just made 3 small holes in the large garbage bag. Fits to my size, exactly my size, and it's there ready. So only thing is, of course, whenever we are wearing any of these PPE, we have to stay hydrated. Precaution which has to be taken, and that is that if you are wearing this, you will sweat a lot and you will get dehydrated and you may fall down. So if you are wearing this, very important, every 2 hours you must take ORS with water or lemon water or some orange juice or copra water. So you have to keep yourself hydrated with salt and water in case you are using this contraption. And it's easy to remove also. There's no worry about inside, outside. It can come out only one way. So you can just take it out and then throw it away. It's not very expensive. I think it's some 20 rupees or 10 rupees or something. Okay. So I thank everyone, and I thank especially the Ambala Ophthalmic Society, Comforts, and AICE for helping me to be with all my nice people in Ambala. As I said, I remember my childhood, my training period. Ambala was the station where I used to board the train to Jammu every time I had to go. So questions?
That was a very nice presentation, and probably it has rested our nerves as well. Everybody is very scared when to start and how to proceed further. Before we take questions, a quick comment from one of the panelists, Dr. Barad sir. Anything to add? So you
Dr.
have
Savitri, there's one question for you. You answered that about
Hello. 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 Hello, madam. Madam, I want more light on this ultraviolet sanitization chambers. So we are nowadays reading a lot about this corona oven. We can you see sterilize our mask, N95 mask, mobile, pen, stationery, and this currency, everything. And within 10 to 15 minutes, even PP kits. Is it harmful? Is it safe? All these things, I think it is quite important. So please.
As far as possible, can you hear me?
Yes,
yes, yes.
You're audible.
As far as possible, we should not reuse what needs to be one-time use material. So N95 mask is the only one which I think we have some information about using it. And after a lot of discussion, we realized that we should not do gas sterilization for that, because gas can remain in those parts of the mask and it will be harmful to the face when you wear it next time. So no gas sterilization. And UV light, we don't know how it is going to damage the threads inside, because it creates heat, UV light. So we have no information whether we can reuse. Only thing we have agreed on is if you can, we can give 3 or 4 N95 to one person. He can, and the same person should take it, just keep it in a cover, in a big brown or whatever color newspaper cover or whatever, and allow it to dry for 2 to 3 days and then re-wear it. The same person should wear his own mask. And that's the only way we can save some money. But we do not recommend any method of re-sterilization of N95. But re-sterilization of the visor, I already mentioned.
And what about the use of UV light in OT? That's another concern that some people are recommending, that UVC can be put up in the OT for disinfection when you are not using.
Yes, actually UV, we have in our old theaters in LV Prasad, we had UV lights in every OR. We had 4, depending on the size of the room, you need to decide how many bulbs are required. So we had 4 bulbs in each room in 20 by 20 feet rooms. In our lab also, we have, our rooms are very small. The lab rooms are 7 into 8 or 10 into 10. So we have just 2 bulbs in each room. So it is definitely useful to have that if you can put that. Only thing is it should not be on when people are inside. It is harmful to the people. So we
Madam,
should
how
have,
much effective?
It is very effective. It is very effective.
We can
have to
depend
have
on.
a red lamp. So there's a red lamp outside. Whenever the UV light switch is on, the red lamp automatically is on.
And the
So
switch also should be outside. So you switch it on from outside, switch it off from outside. But it is very useful. There is no doubt about that.
But other than N95, we can sterilize other things, sanitize other things. No problem.
Like what?
Like this, any other thing, even PP kits, people are saying.
PP kit, what do you mean, sir? I am not sure.
This gown and other things.
Reusing?
Not. Yes.
Oh, I think they are disposable, isn't it?
Yes.
We should use, instead we should use cloth one which we can wash. We prefer
cloth one we can wash.
We can wash.
But,
yeah.
So ultimately, what type of things we should?
Normal surgeries, including cataract surgeries and all the other normal surgeries, cornea surgeries, we are doing with linen gown only, because there we are putting the drape properly so that the water doesn't come on us. And then these, because the virus goes away with washing, so there's no issue with that. Only for the oculoplasty surgery, where there can be blood and body fluid splash or mucous membrane graft, or some of the retinal surgery where there's a lot of water and it comes on our gown and our pajamas, there we are using this thing. For the anesthetist and all also, we are using linen gown only because it will not enter through the skin. But yes, they are wearing full visor, and as I showed that box, and when the intubation and extubation is happening, we are all out. Only they are there. The
Yeah, but he wants to know whether disposable gown can be reused. I don't think we should reuse disposable
yeah,
gown.
because see, if you set it for sterilization, the fibers will become damaged. Then it will not remain waterproof. It will not remain waterproof. So then it will get macerated. So we don't know. Maybe you can try and see, but I think the number of disposable gowns that we have to use in ophthalmology is very less. Only in the isolation room, if the physician is actually examining a patient. So what we decided in our hospital is that if there's a patient who is actually COVID positive and has a eye emergency, we are not going to handle that patient because we can't treat his systemic disease. So if somebody is positive, he will be sent to government hospital. They will take care of his systemic thing, and they will also take care of his ophthalmic emergency. If they ask us to come there and help them out for some particular disease, we are happy to go and help them there. But we don't have a setup to handle that type of patient in our place.
Okay, thank you, madam.
Ma'am, which disinfectant we should use in our LASIK OT for cleaning of our LASIK bed in between our two patients?
The LASIK rooms are very, very sensitive rooms. And even in normal times, it doesn't allow you to use disinfectants, which will, I think it is harmful for the machine. And we have never been able to use any disinfectant in LASIK rooms. So we cannot recommend any chemicals there. I think the company has its own...
Yeah.
So, madam, there in the LASIK room, we can use ultraviolet?
I think, because I think in our LASIK room, we have ultraviolet.
Yeah, ultraviolet is harmless.
That we can use it. Yes.
So for the bed, I would recommend that if you put, you can put a bed sheet, no? So if you put a bed sheet nicely so that the bed is not exposed to the patient and patient lies only on the bed sheet. And when the patient goes out, he can take the bed sheet out and then you dispose it for normal washing. So there's no way that the patient is actually contaminating your bed. You put a bigger bed sheet and let the patient move out along with his own bed sheet, and then you dispose that bed sheet in the linen basket outside.
Thank you, ma'am.
Madam, if you want to use the ultraviolet light in the LASIK OT, then how to go about it?
That company people actually set it up, I think.
Okay.
Maybe
Dr. Brad, you wanted to say something?
Maybe Amit, you can contact Praveen Krishna and find out.
Yes,
because he was instrumental in setting up. But I know that all our LASIK OTs have UV light.
And also, I have seen, I think Indian companies are coming out with making the cylindrical type of UV, the picture that I showed. It will have on a portable base. It has many UV lamps all around, and it can be moved and kept in different places in the room. That kind of devices is going to come into the market now. You must look for that. Instead of fixing bulbs, you have a portable one.
Dr. Brad, you wanted to say something?
Yeah. At the outset, I wanted to congratulate you and Dr. Kapil for having organized such a good meeting. And thank you very much, because these distinguished speakers have really given great information about all aspects of sterilization. Number two, I just want to raise a few points regarding the point of LASIK OT cleanliness has been raised. I think in routine also, COVID or non-COVID, as a matter of courtesy to every patient, we must put as Subhadra has pointed out, we must put a fresh sheet for every patient. As a matter of courtesy. So that, and we should roll that sheet out in front of that patient. Rather, we spread the sheet in front of the patient. When the patient is coming, another person is spreading the sheet in front of the patient so that he understands and he visibly looks that he's being given a fresh sheet, even if there is no COVID. It's a courtesy to a patient.
Exactly.
And very importantly,
Actually, this COVID has brought back basic hygiene and basic etiquettes in many areas, which we as Indians especially were lacking.
At our center, this has been our protocol from day one. Every patient is given a fresh sheet, and the sheet is spread in front of the patient so that he can see. And you raised very well. Secondly, it's very easy to clean. And in the evening, how to clean? What sort of disinfectant to be used? I just want to point out. There's some D solution. I don't know. This HIC team is knowing. There's some that is very, very weak solution is there. That is just like soap water solution, something like that. We clean our walls with that in the evening. We clean our LASIK beds with that in the evening. Just like mopping with a special detergent, something like that. That's not harmful for the optics or any other part of the machine. Another point regarding N95 I wanted to make, or rather I want clarification also from you and Ma'am Savitri. Well, what we are doing is, we have given 3 or 4 masks to every consultant, and we tell them to use it 4 times. And what they do is, they put it in a Ziploc or in a small jar and put it airtight and put it in the sun.
No, but if it is airtight, then it will not evaporate. You expect some moisture inside because it was on your mouth.
No.
So I think it's better to have open.
Let me explain. Before putting in that jar, it is kept open in the sun for 1 or 2 hours, then in the jar,
Yeah.
and for 3 days it is left in the jar in the sun.
Yeah, that's fine.
So
That's fine.
that's what we have been doing. And well, regarding the PP kits, needless to say, they are disposable. And I definitely feel PP kits in our hospitals, other than when we are facing the COVID patients, are really not required at all. That's what I feel. They are required once we are sure that the patient is suffering from this disease. Otherwise, it's all a preventive phenomena that we are observing here. And you rightly point out this very good nomenclature of yellow and red. I'm very delighted to hear it and get it analyzed in a scientific manner. And the patients are graded into that. Mask, maybe N95 or double-layered mask along with a visor, and observing the speaking etiquettes is good enough, I feel. And a shield between the slit lamp and the patient. That's good enough. Wonderful talk, ma'am. We are really delighted to hear both of you. Wonderful talk. Mesmerized, rather. Thank you.
I just want to add one small point that, as I said, worldwide, it's the ophthalmologist, the community ophthalmologist. No person who's working in the COVID ward has actually died in large numbers. The respiratory pulmonologists have not died. It is the ophthalmologist, the dentists who have died. So in my hospital, for last 8 weeks, I have been killing myself telling people, do this, do this, do this. And what I find in the OPD one day morning, consultant comes in and just he has come in from the home. He's wearing a mask and he just went into the room and examining the patient. No glove, no visor, no apron. And he just started typing on the computer. He has no idea who has used that computer. So what I'm trying to say is that the virus is around us, but don't worry what your neighbor is doing. So my neighbor was like, अरे virus हमारे साथ वाले मोहल्ले में आ गया, अब क्या होगा? I told them, कुछ नहीं होगा. You will not get that virus unless you go to that neighbor's house and pick that virus and bring it into your mouth.
Another
point. हमारे अंदर तभी आएगा जब हम अपने हाथ से उसको अपने अंदर डालेंगे या अपनी नाक से उसको अंदर डालेंगे. So if each one, it is not easy. Each one of us learns where my hand is not touching my face, my eyes, mouth, I'm well covered and I'm following the protocol of social distance, not touching things, cleaning my hand. We are safe, but that is a difficult thing to do.
And one more point for the consultants. This is my suggestion also. I would like to invite your comments also. Usually doctors sit in the apron, white coat. I feel that apron is something very loose and there are a lot of holes and gaps in that. I want a linen gown, just like we wear in the OT, which covers from our neck very tightly till our shoes should be worn, so that our apron or our pant or something does act as a fomite. And we just throw out the gown in the evening and it should be washed. And when we reach home, at least our clothes should be as clean as we went there in the morning.
Sir, मैंने तो आपके नाल ना बल्ले बल्ले डांस करना है. In my hospital, I go to my hospital, I remove my shirt, I put on that linen gown जो हम पेशेंट को देते थे, पूरा जैसा आपने डिस्क्राइब किया, और मैं उसी में ओपीडी करती हूँ. मैंने बाकी लोगों को भी बोला कि प्लीज ऐसा ही पहनो, बट दे आर लाइक नहीं, हमको बहुत दम घुटता है, हम अपना एप्रन पहनेंगे. मैंने कहा देखो भाई, गाउन इधर है, मैं बता रही हूँ, प्लीज पहनो. और मैं तो गाउन जैसा आपने बोला ऐसा ही करती. बल्ले बल्ले. थैंक यू.
Ma'am, there was a question regarding gloves. Like some people are advising nitrile gloves or double layered gloves. So is there a particular scenario where we should be using these gloves, or we can use the routine surgical gloves as we were using earlier on?
I think routine gloves. There is no indication for any special gloves.
And directions regarding use of AC in the OPD. Should we switch it on, or it should be kept off as a blanket?
This is summer days. I don't know how you can operate in the OPD without AC. But definitely the ACs which are duct-like, going from one room to the other room. Theoretically, it sounds that they may not be good. But we really don't have in the ophthalmology patients coming with really positive COVID with symptoms. That kind of patients are not going to be entering our hospital. We are not going to allow for them to sit in the OPD. So I think the risk is very minimal, though theoretically the risk is there if it is a duct-like air conditioning. Maybe the single ACs for each room, they are better than duct-like ACs going into different rooms.
So what practically we have done is, because हमारा तो पूरा central AC है OPDs में, so what we did was, number one, all the doors are kept open, so no door touching, no knob touching, and there's some ventilation. And second thing is, not more than 2 people inside the room. So if the optometrist goes in, then I am out. When I go in, optometrist will come out. So the number of people at a given time, and so even the attendant को waiting hall में ही रखो. When all checkup is over, then call the attendant and talk to them. And you can talk to them in a more open space than in the closed space. Because number one, we can't keep that AC off because it becomes very hot with all that gown and mask and everything. And second, lot of diagnostic machines will stop working, like our lasers and some of these machines, the FFA machine and all, they don't work in higher temperature. They just conk off. So, so in the theater, of course, same thing. So what in the theater, they say that don't open the door. Every time door is opened, there's a gush of air and the aerosol, churns up. So try to keep everything, so that we have to tell the optometrist also in the morning only, keep everything at one place. Don't go in, out, andar bahar ja rahe hain, movement kam karo, baatein kam karo. Number of people in that small area keep low, and try to keep as much door, windows. अब हमारे यहाँ windows नहीं है बहुत सारे rooms में, तो ठीक है, अब windows नहीं है तो नहीं है, तो at least door खुला रखो और movement कम रखो और बातें कम करो. और अगर बहुत ज्यादा कुछ बोलना है ना, तो अभी हम पेशेंट को SMS करके भेजते हैं कि भाई हम आपको सारी डिटेल्स भेज देंगे, आप पढ़ लो वेटिंग हॉल में, फिर कोई सवाल है तो आके पूछ लो. And we explain to them that there will be minimal talking. It is for your safety and our safety. और आपकी स्माइल ज्यादा बोलती है और वर्ड्स कम बोलती है.
मास्क में स्माइल नहीं दिखता ना.
मैडम हाथों से दिखता है, आपकी आवाज की झनकार से दिखता है.
Madam, I want to ask one more thing. Because we will have only asymptomatic patient whenever it comes, and in that the load of the virus is going to be quite less.
Yes.
And what about the load in the conjunctiva in that patient? Should we
conjunctiva
worried
is
about
also-
that aerosol?
No, I think that is also very low. I just got a paper to review from somewhere where there are 45 patients COVID positive in the throat swab and nasopharyngeal swab, and asymptomatic patient had one conjunctival swab. They tested all patients, the conjunctival swabs also, and only
Yes.
out of 45, only one patient had the virus positive in the conjunctival swab, and patient was asymptomatic completely. Even I did not have any features, no conjunctivitis also. So out of 45, one. The
So
patient
chances
had-
are quite less, quite less.
One patient was positive.
आ सकता है, कंजंक्टिवा फ्लूइड में हो सकता है हो.
Oh,
So
chances come.
But the
But
lowest
Ma'am, is the
is,
virus viable in
yeah,
the
so use the
epithelial
tissue
cells?
or use a Johnson, but try not to get any fluid from patient onto your hands. And if
anyway,
you
you
touch,
have
then go and
keep
wash
it
with soap
gloved.
and water.
Keep
That is,
gloved when you are examining.
I just want to know one thing. Have you isolated this virus from the tears on any positive patient? Even though he was symptomatic. Has it been isolated from the tears?
They have done only PCR positive in conjunctival swab. That means RNA has been detected, not cultured.
it has been detected.
Yeah, RNA has been detected.
Yes.
There was
It is
another
there.
question.
PCR
Thank
detects RNA.
In fact, karta nahi karta, but it is there.
There was another question regarding the effectivity of sun on N95, that whether it damages the mask
And
material.
no, sunlight will not damage. Sunlight will
Okay.
not.
And and what is your ROP screening protocol nowadays? Like, we have usually accompaniments of 2 people around. So what is now your protocol for ROP screening?
So we have put it on the IROP website. Please download from there. If there are specific questions or somebody wants it, they can email to me. Basic thing is that all the protocol we are following about hand hygiene and all. Only main thing we have changed is previously we used to take the baby from the mother and take it ourselves into the crib, and then we will cuddle it, and then we will give it to the mother. So that we have stopped. So we put the place where the mother has to put the baby with a plastic sheet, and then the mother comes and puts that baby, and then she moves away 6 feet, and then I go examine, and then I move away, and then I ask the mother to come and pick up her baby, and we just look at the eye. And if we are doing laser, then we can put a small oxygen mask that we normally give for oxygen during anesthesia, along with the tube, so the baby's mouth is covered with the mask and the tube. So we are not directly getting the aerosol, but we are wearing N95 mask and gloves. And we can wear linen gown because we are doing laser. So we did a lot of, hopefully these babies are not infected, because during COVID times, actually in many places, they are actually testing the mother and the baby. But we never know. No, we never know. So we take all the precautions. But we are safely doing, we gave Avastin also, and we did lasers also. We're doing screening also. So the full protocol is given on the Indian ROP website.
Many specific consideration that you take for long duration cases. Short duration cases, the guidelines are pretty clear now. For long duration cases, because if it is aerosol generating, especially, it is going to be for a longer duration.
Yep, that is why the N95 mask is there. No, your surgery is not going to be 12 hours. No.
Yeah.
So the mask, actually, they say you can wear for 4 to 6 hours at a stretch. After that, actually, you become hypoxic. At the end of the day, my head is reeling. First few days, it was quite tough to operate. But I did stage 5 surgery, 3 hours with that N95 mask. The first day I did lens sparing 1 hour, and I had some dizziness. But now it's not there. So it's just like going on high altitude. No, after some time, the body gets used to that. So now it's okay, but it just takes little time for our body to get used to it.
Dr. Kapil, any comments?
Just one question to Dr. Savitri. Some doctors ask, is three-layered mask, cloth mask, or different materials, maybe as is seen in the Western countries also, they make different materials, cotton, chiffon, silk, maybe different materials, so that it acts as mechanical barrier as well as electrostatic barrier. Is that as effective or nearly as effective as the 95? They say it's as effective.
I have no idea.
It is there in many websites. It says it's so much information is being passed on cloth masks, efficacy of cloth masks.
So there was very nice information by CDC and on WHO website about the cloth masks. I did a literature search on that. So the cloth masks, it's mentioned that there was a lot of scientific data collected before the surgical mask came. And after that, they have not got too much of recent literature on that, because nobody is using, so nobody is testing them. But that is why WHO finally said that all public should wear masks. Initially, they said don't wear, and then they said, so this cloth mask gives you 50 to 60% protection. The thing is that it should not be wet. Okay, and of course, small virus particles, they may not stop it, but then the virus particles are not directly coming into you. But more difficult is that with the mask on, we keep on touching our face. That is what I see, and that is where the visor works, because it's not about the mask wearing or not wearing, but wearing it properly. You know, you can see on TV how people are wearing the mask, even in your OPD, आधा नीचे आधा ऊपर है, फिर adjust कर रहे हैं, फिर उसी को ऐसे ऐसे कर रहे हैं, फिर ऐसे कर रहे हैं, फिर ऐसे कर रहे हैं. So it's the habit. You know, so I think more than the quality of the mask is what you're doing with that mask.
Dr. Sanjeev Arora and Dr. Vikas, any comments?
Yeah.
If anybody wants that literature, I can share. You can email to me. It's good. Those cloth masks are also, after all, for so many years, we used to do surgery only with cloth masks. For ages, we did surgery with cloth masks. Okay, we didn't have these surgical masks. They only come now. And in fact, even when they're not available, sometimes our nurses and all used to wear cloth masks and we used to do surgery.
Yeah, first of all, I would like to thank both the ma'ams for the enlightening speak that they have provided to us. And I just want to ask one question to Dr. Savitri ma'am. Is this virus is viable in the corneal epithelial cells? Because you have told in your talk that there are receptors on the corneal epithelial surface also.
Yes, I read about that. The cornea and conjunctiva both have that ACE receptors, which are there in the lungs. And that becomes the entry point for the virus.
Okay, thank you.
Great.
So the Eye Bank Association of India is also come up with their guidelines of what they're going to do, because all the corneal transplant has stopped. We started our HRCP. We harvested corneas. So I think those who are cornea surgeons should look at the EBI guidelines and talk to Prashant Garg or Sunita Chaurasia about the use of corneas during this period.
Yeah, the AIOS guideline also has mention about that. And they say that you should not transplant the tissue from COVID positive, known positive patients.
Yes, actually, it says that we can start the eye banking from HCRP and not the voluntary donations, so that we don't know how it is. But anyways, I think this was one of the best webinar on COVID I have heard so far. Thank you so much, Savitri ma'am, and thank you so much, Sudhara ma'am, for enlightening us, giving us the rationale of what we had been using, and clearing so many doubts. And as Dr. Barad said, that this was really one of the best ones. Totally blown away and totally mesmerized. Thank you so much. Over to Amit.
Thank you.
I'd like to invite Dr. Mahesh Manocha, who's our patron, to give a vote of thanks.
Namaskar.
Sir, social distancing रखिए.
I feel greatly honored and privileged to thank the stalwarts in ophthalmology who have opened our eyes. I think I go to OPD and now I thought that I was doing so many mistakes. So I think we will try to improve, and this was quite an eye-opening session. Of course, we are passing through a dark period, and I always feel that there is silver lining at the end of the tunnel. We hope that at this time we have to take precautions, and simultaneously this is a good method of communication. Initially, we were used to go and attend conferences, go from this town to the other. Now this is a newer method where we can have such a good communication between all of us. Thank you very much. Once again, we wish that this talk will prove very useful to all of us. Thank you.
Thank you, sir. And we are only one email away or one phone call away. कभी भी कोई भी doubt है, we are there. And of course, if you have any new information, you have some good information, please share with us. We are always here to learn from each other. And I'm sure that everybody, और अम्बाला तो जुगाड़ का गढ़ है. It's the medical capital. तो वहाँ से तो बहुत अच्छे ideas आएंगे. तो कुछ भी आपके अच्छे ideas हैं, so please share with us. We will also learn.
No, it's beyond doubt that ma'am is just a phone call away, and she always is very helpful. And ma'am, आपने जो answers दिए थे, that also we shared in the group. So it is really great that you are always available for improvising ourselves and our practices. Thanks so much.
I would like to thank Dr. Savitri and Dr. Subhadra on behalf of AOS as well. And I'd like to thank all the panelists and all the attendees. Thank you, everyone.
Thank you so
you.
much.
Bye-bye, ma'am.